Hello, good evening. Welcome to my Aviofensis and the European Fertility Society. We are back once again, and we are here after yesterday's event. And today we are going to introduce you to another event and another topic. So I'm really happy to be back with all of you today as well. As you can see, our special guest, Dr. Abraham Zavala, is with us. So hello, Dr. Zavala. Thank you so much for joining us once again. And it's lovely to have you. And this last time we discussed recurrent pregnancy loss, if I remember correctly.
Yes,
And
that's correct.
today,
Yeah.
exactly. So today we will talk about a different topic: weight, fertility, and whether BMI really matters. So we have the perfect expert to discuss this topic as well, to simply explain what impact BMI can have on infertility. And as always, we will start with the presentation on the topic, and your questions will be answered right after that. So remember, just put those in the chat. Dr. Zavala is the fertility specialist at Clínica Tambre, located in Alicante. He is connecting to us from sunny Alicante, is it?
Well, rainy today, but usually
Oh,
sunny.
okay. All right, got it, of course. Thank you so much for joining. Are we ready to discuss our topic today?
Yeah, delighted to be here and we're ready to start.
Definitely. Thank you so much then, and let's go with our presentation first. And remember, again, put the questions in the chat. You can do it during the presentation and afterwards. And of course, we will definitely take care of those. So let's go.
Okay, great. So, first of all, thank you, Carolina, for having me here again. And today we are going to discuss weight and fertility and what impact the BMI may have on reproductive outcomes. So, the list of topics that we're going to go through today is first of all, we're going to take a look at what effects obesity can have on fertility. We're, of course, going to first start with the definition and talk about how we measure obesity and how we're able to diagnose it. Then we're going to talk about the potential treatments that there are for obesity in assisted reproduction, the risks that can come with obesity in both assisted reproductive treatments and also pregnancy. And finally, we're going to talk about the lifestyle changes that may benefit people that are going through obesity and assisted reproductive treatments. So, first of all, I would like to start out by talking about obesity in a from a purely medical context. Now, one of the last presentations that we had was on PCOS, and while PCOS, one of the characteristics of this condition of this endocrine condition, um, is obesity. We, at least for the purpose of this presentation, I want us to really separate those two concepts, because when we're talking about obesity, we're not talking about everything that comes with PCOS. Just in the same way that when we talk about PCOS, it doesn't always have to be in the presence of obesity. There are different types of PCOS patients, and there are PCOS patients that don't have obesity and that may have a considered normal BMI. So now that we've talked about that, it's really important that we start out by defining what obesity is. And first of all, obesity is a condition that is chronic and highly prevalent. So the way that we could define it is by saying that it is an abnormal or an excessive accumulation of fat, and the way that we diagnose it and measure it is through something called the BMI. You've probably heard about the BMI. BMI means body mass index, and it is a formula that takes into account your weight and height. And we're going to take the weight and divide it by height squared, and that is going to give us a number. Now, if this number is between 18.5 and 24.9, that is going to be considered a normal BMI. Okay. When that number is under 18.5, we would consider that to be underweight, and everything about above 24.9 is going to be considered at least overweight. However, if that BMI is between 25 and 29.9, everything above 29.9 is going to be considered obesity. Okay, there are different obesity groups. So we're going to have obesity group one or category one in people that have a BMI from 30 to 34.9, and severe obesity or grade 2 obesity when this obesity is above 35 of the BMI scale. Now, is BMI the best way to define and measure obesity? Well, no. We've actually seen that it is not the best way to define obesity because it it doesn't take into account many factors. Um, some are actually quite important, such as muscle mass, or actually the amount of fat cells or fat tissue that we may have, the amount of water that we may be holding. So it doesn't take many of these factors into consideration. In fact, it doesn't even take gender into consideration. So we can see how there are many different areas in which we could improve the way that we define and measure obesity. Nonetheless, we know that at least or about 600 million adults worldwide are at least overweight or maybe going through obesity. Among the developed nations, the United States of America has the highest obesity rates in the world. Okay, so now that we've talked about what obesity is or what being overweight is, it's important to talk about how this can impact not just your overall health, but reproductive outcomes. And there are two moments in which the BMI would be of great importance. So one of those moments would be in fertility treatments, be it IVF, egg donation, artificial insemination. And the other point in time in which your BMI will come into play will be during pregnancy. We know that a higher BMI can be associated to negative outcomes in pregnancies. So we have some stats here. We know that in 2019, almost 52.7% of adults in the European Union were considered overweight. And we've seen that there is a link between a higher BMI and fertility. Now, we are going to talk about two important paradigms that we have in or two important dogmas that we have in fertility. That our ideal BMI is going to be between 18.5 and 24.9, and that anything over a BMI of 30 is going to decrease our success outcomes in assisted reproduction. However, there are a lot of factors that come into play when we talk about these outcomes. It's 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 not black and white in the sense that we know that a BMI over 30 is it may affect our reproductive outcomes, but we're not entirely sure how or why. We know that there are some things that come into play that we are going to discuss later on, but also we're not sure whether correcting that improves our outcomes. So those are a lot of the things that we're going to talk about right now. Okay. So in this slide, we have what we call the hormonal axis. So the way that the hormones impact the ovary are going to be, first, a hormone is going to be secreted from the hypothalamus, and that is going to go to the pituitary gland. Okay, so that hormone is the GnRH. This hormones means gonadotropin releasing hormones. Now, we have two gonadotropins that are going to be stimulated through the GnRH, okay? And that's going to be the FSH and the LH. Those are the two gonadotropins that are going to be stimulated with the GnRH. Now, once the FSH and the LH are secreted from the pituitary gland, they are going to head to the ovary where they're going to stimulate the follicle. Now, the follicle is the area in which the egg is going to develop. And the way that the follicle is stimulated is through the FSH and LH, but not at the same time or in the same way. So, depending on the rate of the at which the GnRH is secreted, it's going to either stimulate more FSH release or more LH release. Okay, so it's a very tightly calibrated system so that the follicle receives the optimal stimulation from both of those hormones. Now, this is a purely endocrine system, and we often forget that one of the most important endocrine organs that we have in the body is what we call the adipose tissue or fat tissue. Okay, now the fat tissue is going to have certain hormones that it can release called cytokines. These cytokines, when they are released from the adipose tissue, are going to be called adipokines. Okay, and four of the more important ones, you might have heard of them before because they serve to balance out the certain impulses like the hunger reflex and the satiety reflex. So these hormones are going to be leptin, ghrelin, omentin, and adiponectin. Okay, and these hormones, if they are not secreted in the right way because there's an excess adipose tissue, might affect the way that the sex hormones are regulated. So this may affect how the GnRH is secreted, which can affect how the FSH and LH pulses are stimulated in the pituitary gland. And this is ultimately going to affect how the follicle is stimulated and thus how the egg inside that follicle develops. So this is why it's the impact that an increase in fat tissue can have is so important. And that's also why it's important to make the difference between weight, okay, which can be a combination of different tissues, and a purely fat tissue. Okay. Now, we often forget that an increased BMI not only affects the way that the egg is developed, but it can also affect sperm quality. Okay. An increased amount of fat tissue can affect sperm production and decrease its quality. It can also affect the way the sperm cells move and the amount of normal forms or morphology that the semen quality has. And it can also reduce the fertilization rates that the sperm can have with the egg cells. Now we've seen that in males, a healthy BMI or staying below that 30 kilograms over meter squared improves our sperm quality and fertilization rates. Okay, now we talked about the way that obesity might affect the hormonal development of the egg cell, but how does this alteration of the endocrine axis actually affect our reproductive outcomes? Okay, so let's start out by talking about the follicular development. Okay, so once if the follicle doesn't receive the right stimulation, it's going to create an environment within the follicular fluid. So the follicle has fluid inside of which the egg develops and reaches maturity. But in patients that have obesity, we've seen that the follicular fluid doesn't have the right concentration of the normal components that the follicular fluid should have. And this can affect the egg quality. Okay. Also, we know that an increased BMI may also affect the way that the ovary responds to the natural hormones that your body produces, but it can also affect the way that your ovary responds to the medication that we provide during treatments such as IVF. So that's one of the first steps in which obesity can actually affect reproductive outcomes. Now, it can also make certain procedures more difficult. Okay, and it's important that we know that the tools that we use, such as the ultrasound scan or the aspiration needle during IVF, or the catheter that we use during an embryo transfer, may be affected if there's more adipose tissue. Okay, so when there's more adipose tissue or more fat tissue, we may not be able to see in the same way that we would with less fat tissue. So this can affect the way that we monitor an IVF stimulation cycle, the way that we do the egg collection after a stimulation cycle, and also the way that we see and perform an embryo transfer, mainly because of the way these procedures are usually done by ultrasound guidance. Now, in terms of results, it's important to point out that we have different results from different studies. Okay, so some studies seem to show that an increased BMI may be associated to um, less mature eggs, less amount of eggs collected, less eggs that are correctly fertilized. Um, some studies seem to show that once the eggs are fertilized, there's really no difference in the amount of euploid or aneuploid embryos when compared to patients that have a BMI under 25.9. There are a few studies that show that it may impact the genetic development of the embryos. So it's hard to say for sure how obesity can impact, or specifically at what point obesity can impact the reproductive outcomes. But it seems to reduce implantation rates and also to increase miscarriage rates. And ultimately, it has been shown to reduce live birth rates. So it's important that we individualize the way that we diagnose obesity, the way that we measure it, and we should individualize our patients when deciding what the best type of treatment is. Okay, so we were talking about the different ways in which obesity can impact fertility. So it can come with certain complications to pregnant women. It can increase the rate of women with high blood pressure and gestational diabetes, and diabetes. It can also increase the risks of a C-section or of having a premature delivery. It depending on the um, the amount of BMI, it could also increase mortality risk in pregnancy. And there are dangers of malformations and high birth weight um, in babies from obese mothers. Now, it's important to point out that when we talk about these types of complications, they may or not be related purely to obesity. So many of the risks that we are talking about are usually in the context of obesity along with gestational diabetes, or with regular diabetes mellitus. So it's important that we take this and we understand that we're not talking about just, if my BMI is over 30, that means that I'm exposed to all of these potential complications. No, but it does open the door to other complications such as high blood pressure and diabetes, which in turn can increase the rate of complications during pregnancy and delivery. So the question is, how do we treat people that have an increased BMI, or how do we treat women with an increased BMI? Well, first of all, I think it's important to let patients know that while it is a good idea to try and decrease the amount of fat tissue when the BMI is above a certain threshold, we're not entirely sure how a decrease in weight, how what amount of positive impact that may have on treatment, because we have mixed results from different studies. So we know that one of the ways that obesity may affect reproductive outcomes is because women with an increased amount of adipose tissue or fat tissue um, may not ovulate regularly. Okay, and that's something that we also see in other conditions, such as PCOS. So we know that decreasing your weight does usually restart the ovulation process. So that is one good reason to to uh, to reduce the weight, and to try and have that weight reduction. However, we've seen that in other studies in which we've had, for example, patients with women with obesity, um, that they go through egg donation treatment, it seems that even though we're using an egg donor to generate an embryo, we're still seeing um, an increased rate of adverse outcomes. So we're not entirely sure in what stages of the reproductive process a decrease in weight can have the most impact. We know that it is beneficial to lose weight for your overall health and for certain improvements in reproductive outcomes, but we're not entirely sure whether that may impact the treatment as a whole. Now, there are also different medications that we may use to try and decrease BMI when lifestyle changes, when diet haven't been effective. A lot of patients ask whether there's a a diet that we would recommend for decreasing weight. Um, a lot of patients think that it may be a good idea to reduce fats. Well, with there isn't a standard diet that we would recommend, but we what we do recommend is going into a healthy caloric deficit. Okay, so that means consuming less calories than you're using. Okay, so that would be the most important advice that we could give in terms of of a diet. And in regards to diets that leave out fats, well, we don't really recommend that. See, most of the hormones that are important to the hormonal axis that we were talking about come directly from cholesterol. That doesn't mean if you take more cholesterol or have a higher fat intake that that's going to improve. But we certainly don't think that cutting them out is going to benefit the way that those hormones behave. So it's very important that we understand that our goal would be a caloric deficit in the sense of an ideal diet. Now, when diets aren't enough, there are medications that we may use. I think that that would be a whole another topic. So I'm just going to mention the four more common ones, such as orlistat, phentermine, the combination of bupropion and naltrexone, and one that is very popular right now, which is the semaglutide or Ozempic. While those four medications, by the way, I'm mentioning those four because it's the four that are approved in the US and some of these are approved in Europe. Um, these drugs are great at reducing weight, um, but it doesn't seem like there's an improvement in fertility rates with these drugs. There are certainly some promising results with drugs like Ozempic, but with it being contraindicated during pregnancy, there are very few studies that we can use to actually assess the effect that it can have on fertility outcomes. Okay, and that would be it for me. I'd be happy to take your questions now.
My BMI is normal, but I have hypothyroidism and currently I'm taking thyroxine. What is the chance of getting pregnant through IVF? I'm 34.
Okay, so it's going to depend a lot on how much your TSH hormone, which is the hormone that we use to define whether it's a hypothyroidism or hyperthyroidism, what the levels are and how closely you are controlling it with that dose of levothyroxine. So we've seen that it may not have a much of an impact, hypothyroidism, I mean, on the stimulation protocol that we use. results should not be that different, but it is going to have an impact on the embryo transfer and subsequent pregnancy. So, you do know that having an uncontrolled TSH level, or thyroid hormone levels, um, is related to adverse pregnancy outcomes, such as miscarriages, implantation failures. But it's also going to be very important to have that regulated for the fetus's neurodevelopment. But this shouldn't affect your chances of achieving pregnancy through IVF.
Okay. And can you tell us what is the TSH level? Is it like that someone have to look at or look out for, let's say?
Yeah. Okay. So TSH levels in the normal population is going to be, depending on the lab, depending on the guidelines, depending on the country, it's going to be around 0.4 to about 4 to 4.5. That's going to be the normal level. However, there
Mm-hmm.
are going to be two special populations in which we're going to use different levels to measure the TSH, and that's going to be in patients undergoing fertility treatment and in pregnant women. Okay, in these two populations, we're going to want to have a threshold of 2.5. We're going to want our
Mm-hmm.
TSH hormone to be below 2.5.
Okay. Yeah, that's why I wanted to clarify for everyone, right? So you need to remember that it's 2.5. As you said as well, of course, we've spoken about it during our webinars many times, but I think it's good to repeat that over and over again, so we can
Yeah,
make sure that we remember this as well. Of course, thank you so much
yeah,
for your first
definitely.
question. I do believe it was very well explained for you, Ellen. So thanks a lot, and let's have a look at the next question. Okay, so here's the message. There is some evidence that some nutrition, some supplements can improve outcomes, including live birth rates, regardless of weight loss. Can you comment on that?
Dr. Zavala, fertility issues are hard. Weight loss is also very hard. Yes, there is some evidence that some nutrients and some supplements can improve outcomes, including live birth rates, regardless of weight loss. Getting commonplace. Yeah. So, this is so true. I mean, I with fertility treatments, sometimes we prescribe weight loss, like it's like you go to the pharmacy, you get the medication, and then you lose 10 kilos. It doesn't quite work like that, and it basically involves changing your lifestyle to be able to achieve an important weight loss, whatever the amount of weight that you need to lose. Now, as we said, as we talked about, one of the ways that an increased BMI or an increased amount of fat tissue can affect the fertility outcome is through the follicular development. Okay, we're going to have an inadequate stimulation of the follicle, which in turn is going to affect how the egg develops and matures. So there are going to be certain supplements that may aid um, the the development of that follicle. One of those is going to be inositol. Okay, inositol is going to act in a way similar as metformin would act. In fact, some studies have shown that inositol is even able to resume ovulation, which is one of the reasons that we would use, for example, metformin in patients with PCOS. So inositol is one of the important supplements that we may take. either myo-inositol or chiro-inositol. They are both adequate for this purpose. And also, other supplements that have an impact on follicular development, such as ubiquinol and coenzyme Q10.
Mhm. Okay. Thank you. Thank you, Connor, for your question. Again, I do hope that it was useful for you. If you have anything else to add, you can add it right now. And now we will go for a question from Belinda. I've been going through IVF for over 5 years now. When I started, I had healthy BMI, but now I am the heaviest I have ever been, BMI 31.5. I feel this increase in weight for me is related to years of high dose stim meds and steroids. Have you seen this? I'm actively trying to lose weight now before my next round in May.
Yeah.
Anything you can add?
I mean, so 5 years is quite a long time. I know what you're saying because we've seen it
Mhm.
in the clinic. Um, and this goes back to what we were talking in the beginning of the presentation. Um, so BMI is going to evaluate weight as a whole. Okay, it's not going to evaluate what is increasing that weight or the weight that weight is composed. Okay, so it's not going to distinguish whether there are 2 extra kilograms of water, or there are 2 kilograms of muscle tissue, or there are 2 extra kilograms of fat tissue. Okay, and now hormones, especially hormones such as progesterone or corticosteroids, have been shown to increase the retention of fluids. So that can be a factor, but it's also important to remember that IVF stimulation is going to increase the amount of estrogens that we're exposed to, the amount of FSH, the amount of LH, the impact that this can have on our hunger centers, and and how that's going to impact our everyday life is hard to tell. So that's why it's important that to address this issue and see what behavioral or what pharmacological change we can make to improve this condition.
All right. Thank you again, indeed, for that. I don't see more questions, but we still have around 15 minutes. So if you have anything else you wish to add, you can. There's still time for it. If not, we will be finishing. But thank you so much for joining and for your questions. Well, I would like to also perhaps ask you while we wait, any piece of advice who is struggling with, it can be hard, right? Losing weight,
Mhm.
preparing for IVF. Any piece of advice for anyone who's going through this right now?
Yeah, I mean, it's something quite difficult that you know we've all, regardless, I haven't gone through IVF, but I've struggled with weight, with weight gain, weight loss, and I know a lot of people around me that have also gone through that, and a lot of my patients are in this situation. So it's something very common that we all either are going through that struggle ourselves, or we know people that are going through that struggle. And sometimes it's not as or most of the time it's not as easy as, oh, just eat less and exercise more. There are a lot of caveats and a lot of pitfalls to that, to what the right nutrition should be, that is sustainable throughout time, what the right exercise regimen is, that is also sustainable throughout time, that it's not something that you're just going to do for a month or two, um, because that's part of the difficulty in treating obesity, that we fall back in it, after a certain amount of time. So my advice would be to take it up with your doctor, discuss the difficulties that you're having, so that we may find the best way to help you and to make it a permanent change in your lifestyle.
That sounds good, of course. Thank you so much for yet another answer. And there's one more question that I see here right now. Well, so let's have a look. In case of double donation, where stimulation of ovaries are not a case, is the increased BMI? Not sure here. Sorry.
No, yeah. And that's a difficult question, okay? Because an increased BMI doesn't just affect the way that the egg develops. It might also affect the way that the receptivity of your endometrium is expressed. Um, there are a few studies. Well, I can think of a couple right now that have been done on this subject. However, one of the studies was in women with an increased BMI that were receiving egg donors, and those did see a decrease in pregnancy rates and implantation. However, the donor's BMI wasn't taken into account, so we don't know where those eggs were coming from or how they were developing. And then there's another study that took a cohort of, I believe it was about 10,000 donors, or 10,000 egg cells from donors, um, from a normal BMI. And that didn't have that didn't see much of a difference in pregnancy rates between increased and normal BMI. So I think that it's hard to give a clear yes or no answer to that question. Um, but our recommendations stand saying that that it's always recommendable to lose weight when undergoing fertility treatments.
Okay. Thank you for yet another question. I do hope it was again helpful. Belinda has added one more question. Would you say being overweight might affect the way we absorb injectable progesterone? I usually need PIO after an embryo transfer, but my levels don't meet required level.
That's a good point that I actually did not mention in the presentation. So thank you for that, Belinda. The one of the effects that obesity can have on fertility treatments. Well, I did kind of mention it because I was talking about how the ovary might not be as responsive. Um, so one of the things that we've seen with patients with an increased BMI is that they often need more medication to get the same effect.
Mm.
So in that case, it could be a factor in the way that the medication is distributed, that maybe we're not getting the same result that we would see with a decreased BMI. Now, is there a difference between overweight and obesity grade one, and how does that impact the amount of medication that we need? Hard to tell. I think that it's difficult to say specifically how much more medication you would need to get that same effect. As I said, BMI just tells us that there's an increased weight, but it doesn't tell us what that weight is composed of. So I'm not sure what would be the appropriate dose in this case, but we have seen that patients with an increased BMI often need higher doses of the same medication.
Okay. Thank you again for yet another question. And we will go to our very first question. Actually, if you mentioned that 2.5 level for TSH, can you just clarify this a little bit more for Ellen as well, for us, of course? Thank you.
Yeah, okay. So we were talking about how TSH levels in the general population are, and I specified how depending on, lab values, specific guidelines, and the country that you are being tested in, are usually going to be normal TSH values between zero point 0.4 and 4.5. Okay. Now, in women, there are two populations in which we may want different values, and that would be in women trying to achieve pregnancy through fertility treatments or in pregnant women. In these populations, we're going to want TSH values below 2.5.
Yep. I hope that, again, helped. Let us know, of course. If you have anything else, you can still type the questions in the chat. If not, remember that Dr. Zavala has his team at Clínica Tambre. They will be ready for any of your questions as well. So I think that was our final question for today. But thanks everyone for your active participation today. Dr. Zavala, it's always lovely to have you, and it's always great to listen to you and how you explain everything. You make it sound definitely easy. So thanks,
Thank
thanks
you.
a lot for that. For any final words for today?
No, thank you for having here and looking forward to coming back soon.
Yeah, we are definitely looking forward to some more events with you. There are still more to come, so stay tuned. As you can see, there are some questions in the chat. Thanking you, very thorough, so thank you. So thanks a lot for being with us today. We do hope it was helpful. I do believe so, for sure. And of course, remember, we will be back. Actually, there is IVF live stories tomorrow, so I hope you will be able to join us this time. Our special guest will be sharing her own personal IVF journey. So you will be able to perhaps get inspired. So I can only encourage you to go to our My IVF Answers website and sign up. There we will be live tomorrow at 5:30 London time. So I hope you can join us. But of course, we will be back with more events next week and so on. So thanks a lot for today. Have a lovely evening, Dr. Zavala. See you soon. And as always, thanks a lot for this session. Take care.
Okay.
Bye.
Good evening, everyone. Bye.